So I will do the next presentation, and my presentation will focus on aneuploidy screening. It is another area in our country here where we still lag behind, where we are still stuck in ancient days of clinical practice. So I'm going to address some of the issues which I think we may have to reflect as practitioners in women's health, so that we can try to improve ourselves as a people, and also individually as a practitioner. You would want to practice in an ancient way when you are a modern person. So that is what I want to try and address with my presentation. I'll just share my screen. Admin, you can just confirm. Thank you so much. I think I was muted, but now I'm not. So I was saying thank you so much, Mr. Kumbula, and it was a pleasure to hear you speaking. So what we need to do now is to move on to the next talk, which will be on aneuploidy screening. Like I highlighted that, look, the times have moved, and we need to move with them. So I'll just take you through the historical line, which may make you understand why certain practice is too prevalent in our own country here, and probably beyond our country in Africa, because Africa is a village. When Dr. Mangisa was presenting, only 30% of women in Cape Town, which she labeled a middle income country, book their pregnant or had a scan or had a dating scan, something like that, book their pregnancy for a dating scan, which is probably the same as ours. So Africa is a village. We all practice in the same way, more or less, but our ways need to be updated because they are now outdated for our populations who are global citizens. They travel everywhere. They've been to every part of the world. They know what it means to have arrived and to be behind. So it is for this reason that I've decided to share with you my thoughts on this topic. So if you look on the left here, in 1970s, it was okay to just tell a woman that, look, you are above the age of 35. Down syndrome babies are known to occur to women above the age of 35. Go and have your amniocentesis jab so that we can know if your baby has got Downs or has no Downs. It was okay in the 1970s, but there was a problem in those 1970s. Babies with Downs continued to be born in women who were below the age of 35. Before then, the 35 years and older were making up 5% of the pregnancy population. So more than 50% of Downs occurred in women who were below the age of 35. So people discovered that it was not enough to just be above the age of 35. They introduced alpha fetal protein. Alpha fetal protein, which picked a modest number of Down syndrome. This is why you see that some of our laboratories are still stuck in 1984. In 2021, we have a laboratory which is still reporting alpha fetal protein. And they will tell you that this alpha fetal protein is high. Go send somebody for a high resolution scan to exclude myelomeningocele. Who does that in 2022? It is just a stuck mindset where people are now doing scans where spines can be examined properly, and
excuse Dr. Verenga. Excuse
Yes.
Dr. Verenga. We are seeing on your screen the 11 to 13 pre-course quiz. We are not seeing the slide you are presenting on currently.
Right, sorry about that. Admin, please be vigilant. I was asking about this. Let me do something to make sure I present to you the right. Okay, so you are seeing the 11 to 13 week
pre-course quiz.
Okay.
Which is not in slideshow as well.
Okay. So probably it's okay. I'll just briefly run the quiz, then I'll continue with my presentation. I jumped the quiz, but let me just briefly run them to just see how good we are performing. So in the next probably 30 seconds, just look at that picture there. I hope it's clear where you are. Which one is the ductus venosus in the picture shown? So if you could just identify the ductus venosus using the arrows, which one is the ductus venosus? That's 11 to 13 week image of a ductus venosus. So which one of that, where the arrows are pointing, just try to identify the ductus venosus. Then this is an image of the ductus venosus. You can just look at it and tell us if the ductus venosus is normal. You don't have to send your answers. You will mark for yourself by the end you finish this talk. You should know whether you got it or you didn't. So is the ductus venosus Doppler normal? That's 11 to 13 weeks ductus venosus assessment. So ask yourself this question and you answer on your own, then you mark for yourself so that you know whether learning took place or it didn't. Is the nasal bone present or not? So that's the image there. This more applies to people who scan. Of course, people who don't scan it, this will be very difficult to answer. But people who scan, is the nasal bone present or absent? Then which one is the knuckle translucency? You can try to identify it on this image. I'll show you the same image before I finish and tell you what the correct answers are, depending on your understanding of my talk. Is the tricuspid regurgitation present here? Is it present or it's absent? Tricuspid regurgitation. Is there tricuspid regurgitation? Thank you. That's the short quiz. Let me minimize this so that I could share the other presentation I was on. Maybe I'll just close it. Cancel. Just give me a second. I'm going back to my presentation. I'll just stop the share and reshare with you. I believe you can now see a new screen. Admin, please confirm a new screen with evaluation of aneuploidy screening.
We can now see a new screen, Dr. Verenga.
Thank you so much. Thank you. So I was saying there has been evolution over the years. Where we started in the 1970s, it was okay to just tell a woman that you have 35 years because you are somehow 35, go for Down syndrome screening, because that is what people had seen, that if you are above the age of 35, the probability of having a baby with Downs is higher. So women were just given a jab, an amniocentesis jab, 35. But alas, more than 50% of women above the age of 35 continued to have babies below the age of 35, continue to have babies Downs. So people noted that, look, we could still have babies Downs in women who are below the age of 35. As a result, serum alpha fetoprotein was introduced to try and improve the detection rate with still a modest increase. This is what I was saying, that unfortunately, Africa being Africa, you will see that our laboratories, whenever you ask women to be screened for Down syndrome, using either first trimester, especially using first trimester screening, they still go on and report things like alpha fetal protein, sometimes serum alpha fetal protein. Even when you do amniotic fluid, sometimes you see them reporting alpha fetal protein when they are looking for chromosome abnormalities. But what I'm saying is medicine has moved in such a way that some of the markers which was to want to apply in this day have been overtaken by better screening methods. So triple test was introduced to try and augment the effects of the performance of serum alpha fetal protein. But this screening method could only identify up to 2/3 of potential downs. So it was about 65% the detection rate if you use the triple test here. Of course, you could improve it with the quadruple test to around 80%. But the problem of using the triple and the quadruple test is that these are second trimester tests. In other words, they are late tests. They come in very late for good antenatal care kind of plan. It is better to screen pregnancy at the beginning than to screen for pregnancy halfway. We know that the trauma to the parents is more devastating if you tell a woman who is 24 weeks that your baby has got Downs than to tell a woman who is about 15, 16 weeks. So this is the problem with this triple test. It's a test which is still happening in our country, but it's not a test that we desire to have because its performance is very questionable. If you tell a woman that I'm going to subject you to a test that will only pick 2/3 of potential problems, everyone will run away. Even if it is you yourself, you run away from that kind of test because you're saying there's a potential that 1/3 of the baby's Downs can be missed. So it's not a good test. And it was introduced in the 1980s. In the 1990s, Professor Aneuploidy discovered that the nuchal or the fluid behind the baby's neck had some prediction for Down syndrome. And he noted that almost 60% of babies with Down syndrome have some abnormal nuchal, and it was introduced in the 90s. But the problem of using the nuchal alone is that it was picking about 60% of babies' Downs. So that means it could potentially miss the others who have otherwise a normal nuchal translucency. I think generally in our country, and probably other African states, we are still stuck here at the nuchal translucency. Most women in our country, they actually go and they have a scan and have a nuchal scan, and they are told your baby has no Down syndrome. Whenever we ask women, have you been screened for Down syndrome? The next thing that they are going to tell us that I went for a scan and they measured something behind the baby's neck and they told me that my baby is okay. It is wrong. We are not in the 1990s when evidence was paused concerning this condition. In other words, we are keeping women in 1990s when we all know that we are 20 something people. Because medicine moves, we can't be stuck. It is not right to be stuck in some ancient times and you continue there like nobody has moved. Everybody has moved. Then in the 2000s, the group of Professor Aneuploidy and others, they discovered that there are some chemical substances produced by the placenta, which are papier and free beta HCG, which can be added together with the nuchal translucence, the woman's age, and improve the detection rate to almost 90%. So this is the test that was applied to women and is still being applied today. However, in our modern times, in the 2010s, there around 2012, people discovered that there is actually some small pieces of the baby's DNA in the woman's blood. So whenever the baby's DNA breaks down, some free or loose DNA, which is outside the nucleus, outside the cells, go into the woman's blood and mingle with the woman's free DNA. Because all of us, when our DNA breaks into pieces, some of it get into our blood. So they discovered that it is possible now to harvest the woman's blood and compare the woman's DNA and that of the small pieces of the baby's DNA and come through a laboratory process be able to predict Down syndrome, Edwards, Fetal. Now the test is being applied on chromosome number 1 to number 23, including some deletion syndromes. So this is where we are now. So you can actually gauge yourself. You can look at this chart and ask yourself and say, where am I practicing? You could be practicing in the 1980s, where you only see them in second trimester and told them to go for triple tests, or you could be stuck in 1970s. In 1970s, what was happening? Nobody was being offered screening for Downs. It was only those who were above the age of 35. There are people who still do this. They only offer Down syndrome to people who are above the age of 35. So what I'm saying is this belongs to 1970s. It's not modern antenatal care practice to do that. Some just offer NT. So this is 90s. This is 1990s where you are stuck. Then if you are offering combined tests, you are probably living in modern times. It's still a good option. So that means a scan plus blood test. After you have sent them for the nuchal scan, together with the nuchal scan request, you give them a blood test request so that they can proceed to the laboratory if their papillae and beta-CG measured and the results calculated based on the woman's age, the knockout translucency, and the results of the papillae and beta-CG. That's a combined test. That's a better test for screening for aneuploidy. If the woman can afford, it is even better to offer them fetal self-free DNA tests. The people in our country are taking this test, believe you me. We will share with you at the Congress, the African Congress, what proportion of our women are actually taking NIPT as an alternative to the combined for Down syndrome screening. So this is modern obstetric care practice, where you offer women the screening. One of the reasons why probably we are still stuck in these times is because of this pyramid of care, which is still very much a 1929 pyramid of care for most of our women in Zimbabwe. Most of our women do not book early. As a result, they are not benefits, or they are not part of the invasion of the pyramid of care, which was discussed, or which was championed for by Professor Kipros when he argued that we need to turn the pyramid of care so that women can present at 12 weeks to be offered screening for pregnancy complications, amongst them aneuploidy screening. So this turning of the pyramid of care is still to be realized in African settings. Other countries are moving so fast that their women are now presenting at 10 weeks to be offered fetal cell-free DNA tests and a very early scan for viability. But we have not even turned the pyramid of care at all in African settings. I'm addressing both the public sector and the private sector. To say most of the private sector, they are still here. But I'm saying this is old, archaic, and modern to continue to see women in second trimester or to do nothing when they come to us at 12 weeks. We should offer them aneuploidy screening and preeclampsia screening, as another speaker will tell you in this meeting. So this is the modern way of practicing obstetrics. So the purpose of the 11 to 13 weeks is something that we all know, that we need to assess women for risk factors, for major fetal defect, for HIV, Down syndrome, preeclampsia, and fetal growth restriction, and preterm birth. All these risk factors have to be assessed, and of course we need to do the basics. The basics are these. These are basics: the pregnancy, determine number of fetus, do chorionicity. My colleagues have emphasized that, and localize the placenta. Well, some women, you can see in first trimester that the placenta is really seated on the os, so that when they bleed, you're not surprised why they are bleeding. And this is what is against us, as you can see there, that these are the numbers for early booking, that is booking before 16 weeks. The same as in Cape Town, where probably I think 30% were being scanned. If you look at ours, only about 29% at best, close to 1/3 of our women only book before 16 weeks. So we are still stuck in old times that make practice of modern obstetrics very complicated for ourselves. Then, however, our women actually come to the clinics more than we may expect, so that their base, 89% of our pregnant women, they attend at least four ANC visits. So what it means is that our women have the practice in them, but we need to change the time of the presentation. We need to convince our people that there is no glory or there is no advantage in hiding pregnancy the first 3 months and only present when you are 5 months pregnant, so that they can understand that pregnancy is better managed if they present early. I've just put some key images that we need for the 11 to 13 week scan. I actually thought through this very hard and tough, because I discovered that we have been trying to train our fellows on how to perform 11 to 13 week scan according to Fetal Medicine Foundation protocol. But one of the stumbling block we are having is that we are not having enough numbers to be able to train up to good competency. We are not having enough numbers. As you can see from that chart which I presented, only 30% present after 16 weeks. We don't know what percentage before 16 weeks. We don't know what percentage present before 14 weeks. Probably it's way less. So as a result, we are having challenges even in trying to train people to gain competence. But I've decided that probably to try and improve or to make it quicker, when people decide to do 11 to 13 week scan, there are 3 very important images that they have to obtain. One of them is this one, the CRL image, the crown rump length image. What does it show? It shows us the baby's head here, nicely covered with the skull. It shows us the nasal bone. It shows us the baby's chin. It shows us the baby's neck. And it shows us that there is brain there. There is not too much fluid. On top of that, it shows us that the anterior abdominal wall is covered. And it shows us the fetal bladder and shows us the skin at the back. So with this image, we can actually screen for major fetal defects that range from anencephaly, holoprosencephaly. We can screen for anterior abdominal wall defects such as exomphalos, gastroschisis, and probably large myelomeningocele. The same image, this one is not as clear, probably this one is too dark, but this is good for measuring nuchal translucency. But if we zoom in on the image of the nuchal translucency, we can see the back of the brain here, the one we call the brainstem hospital bone ratio. It can enhance the screen for myelomeningocele. So for people who meet first trimester scan women, probably this is the image you need to obtain to rule out major defects that we have to screen for. Anencephalies, gastroschisis, exomphalos, large myelomeningocele, and probably bladder extrophy to suspect it, if we can obtain a proper CRL. Then the next image is of course to measure the nuchal translucency, which is demonstrated here. The settings are probably about right because you need to darken your screen to be able to see the nuchal space. What you are seeing below here is the amnion. The amnion is not fused to the chorion before 15 weeks. So do not mistake the amnion for the baby skin and you measure this space. The nuchal in this case is this one. It's not this space. And of course, the standards for doing it properly are outlined in the next slide here. Sorry. So the standards are what are outlined here to say how should you measure the nuchal. The baby should be in mid-sagittal plane. In mid-sagittal, that means you can see the nasal bone and the tip of the nose. This is the nasal bone below and the skin on top. And this is a maxilla. You are not seeing the zygoma. The moment you see the zygoma, you know that you are oblique. And you can see again the nuchal space here. And this is what I was referring to as because this is the brainstem, and this is the fourth ventricle, and this is the cisterna magna space. So this space can be used to screen for large myelomeningocele as well. But the most important image for the 11 to 13 week is this image after the CRL, which you have to use for dating. And remember, nuchal translucency is assessed based on the CRL, whether it is normal or abnormal. And the neck has to be in neutral position and the space has to be clear. You have to lower down the gain. You may have to increase it, depending on your machine, increase or decrease the dynamic range to get an image as clear as this one. And of course, the nasal bone and the tip of the nose should be seen. And your image should only have the head and the thorax in the screen. That's a standard and a very important image for the 11 to 13 week scan. I will jump the actual process of Downs. I'll just go to some images. As a complement, when women come to us for screening for Downs, after looking at their age and the nuchal translucency, we go on to assess the ductus venosus. The ductus venosus, remember, is a continuation of the umbilical vein. And because it is cone-shaped, it narrows as it goes towards the heart. It causes aliasing, and the aliasing will give you an orange appearance on the color Doppler. So where you see the aliasing is where the ductus venosus is, because it's cone-shaped in shape, and it causes aliasing or turbulence or flow in the blood. And as you can see there. So that's the ductus venosus. This is the normal one. The one below here shows a reversal of the air wave in the ductus venosus. I think my other colleague has already explained the interpretation of the ductus venosus. Then on top of that, we check the nasal bone. I've already shown you in the other image that the nasal bone is a more hyperechoic area just below the skin of the nose. What you are seeing there is the tip of the nose and the skin of the nose, and the structure which is more hyperechoic there is the nasal bone. In a baby such as this one, there is no nasal bone here. What you are seeing is just the skin and something that is less echogenic than the skin. So this baby has an absent nasal bone, the one below, the picture below there. And this is the tricuspid regurgitation. How do we do it? We just put the pulse wave gauge across the tricuspid valve, put 1/3 in the atrium, 2/3 in the ventricle, and you record your pulse wave tracing. Within this pulse wave tracing, we're going to have what we call arterial systole waveform here, which you can see represented. And this is due to the flapping of the valves you see. But if there is indeed a regurgitation which is significant, you are going to see significant flow, which has a velocity of more than 60 centimeters per second, as shown on the picture below there, where there was tricuspid regurgitation. All these abnormalities I've mentioned, they aid to the screening algorithm. so that the screening algorithm, instead of picking up 85 to 90%, you improve the detection rate to above 95%. So in a country such as ours, where most of our women are not affording to go for the blood test costs $70 by the way. So most of our women are not affording this $70 to go for PAPA and BTCG. We are offering them screening using these ultrasound markers and their maternal age. So we are using maternal age and all these markers. So in a country where the use of ultrasound is as prevalent as in Zimbabwe, in some towns, of course, it is better that sonographers who see 11 to 13-week babies at least know how to look for these other markers to try and improve the detection rate of the ultrasound scan-only based method. Because just using nuclear translucence on its own, unfortunately, you are going to detect less and less babies, and you miss more, and you falsify, tell women that their babies are okay when they are indeed not okay. So these skills, they need to be learned. We have a platform where we train, but we need numbers. We need people who see women at 11 to 13 weeks to encourage them and to let them know that that is the best way for pregnancy risk to be assessed, not at 16 weeks, not at 20 weeks, because that is late. The second most important image after those first two I showed you is this image which you see on the screen right now, is the image of the BPD in first trimester. This image should be done by anyone who decides that they want to look at the baby at 11 to 13 weeks. What do we see? We see the midline, we see the choroid plexuses here. And the moment we see this image, the way it is looking, we have excluded anencephaly, we have excluded alobar holoprosencephaly. Alobar holoprosencephaly, in our situation, I'm sorry to tell you that the median gestational age of diagnosis of alobar holoprosencephaly is beyond 28 weeks in our setup. Most women come to us in third trimester. If you ask them whether they had the first trimester scan, they will tell you, yes, I had the first trimester scan and I was told my baby is normal. The reason why it is like that is because people who do these scans are not doing this image, which I'm showing you right now. If everyone who does the scan makes an effort to just go and obtain biparietal diameter in a first trimester, we are not going to diagnose anencephaly at 30 weeks, holoprosencephaly at 35 weeks, like what is happening at the moment. So remember this image, very important image. I'm not going to emphasize the span. So we know that with early anomaly scanning, there are some easy defects which you can obtain using the most important images that I have already shown you. If you are able to do a proper first crown rump length of the baby, you will be able to see that this baby's brain doesn't look normal. It's not nicely covered as the one I showed you. And this is acrania, which will degenerate to anencephaly if the pregnancy continues. You'll be able to see that there's a large exomphalos here. Just with one image, you'll be able to pick up all these very bad defects. You'll be able to see that this fetus is a megacystis here. And you'll also be able to see that there is something that looks funny on the baby's back, which is a large myelomeningocele. And if you do the biparietal diameter, you'll be able to pick alobar holoprosencephaly. There. It is a very common condition you will see with our fetal defects that we pick it quite very early, quite often. Alobar, it's a leader condition. Nobody goes home, whether you're in Japan, Sydney, it doesn't matter where you are. If you have alobar holoprosencephaly, you are leader. Even if you are 40 weeks in your mother's womb, you can't leave. So it is this kind of conditions That makes us say, look, guys, we can improve ourselves. Those who scan can scan properly and pick up this kind of conditions. Right. So locally, what is it we are doing? Because we shouldn't be talkers. We should not just talk and do nothing. Because look, people who talk, they will not achieve anything. We have to be men of action to be able to do something about our situation. So this is what we have started to do. I've already told you that we are through the Fetal Medicine Foundation UK. Those who are involved in fetal medicine, you know that this is a global program that is used internationally to screen for Down syndrome. So for you to obtain this license, you have to be able to successfully pass the 11 to 13 week module on the FMF website, and to have your nucleus examined and be certified for competency. And you will qualify to have this program on your computer. It will be given to you for free as long as you maintain your license. The license is for free, courtesy of the Fetal Medicine Foundation. So with this program, we are able to calculate the risks for Down syndrome. When you are saying you have calculated somebody's risk for Down syndrome, they should have a known risk. You don't just say, I've done your nuchal, your risk is low. No, what is the actual risk? How did the nuchal modify their a priori risk? As you are aware, every woman who decides that they want to become pregnant, they have an a priori risk which is based on their age of Down syndrome. So the question is, when you do something on that woman, whether you do the scan or the blood test, how does all this affect the a priori risk? Does the a priori risk become worse or it becomes better? So this is what the calculator will be able to do for us. So we can use all these parameters for us to calculate Down syndrome. And these are the detection rates I've put there. But we are using this one for most of the government patients. For the private sector, we are able to use this. But for government patients, we are using this number 2. So we are screening for Down syndrome using that algorithm. These are the other conditions that the application screens for: preeclampsia, fetal growth restriction, and preterm birth. I will not talk about that now. And this is just the handling of the NT here, to say a normal NT is not equal to normal. The woman has to be offered combined test or fetal cell-free DNA. For those who are just doing NT, if your NT is normal, don't tell a woman you have no Down syndrome. They should proceed and have a combined test or a fetal cell-free DNA test, depending on what they can afford. If the NT is abnormal, it does not mean their baby is Down. They can proceed to have a combined test or a fetal cell-free DNA test. That is if it is below the 99th centile. The 99th centile is now about 3 millimeters. If they do this and it's a high risk, then of course we offer them CVS and the amnio. As you are aware, we're not doing amnio because Lancet is not handling CVS samples. So we are only sending amnios to Lancet. So what about if NT is greater than 3 millimeters? What do we do? If it is greater than 3 millimeters, because for an NT greater than 3 millimeters, the risk of having a chromosomal defects will rise to something like 25%. So the moment we have a 1 in 4 chance of having a chromosomal defect, you cannot proceed and do a screening test. You now can proceed and do a diagnostic test. Because we are saying the risk is so high, so that we cannot honestly want to do a screening test when the risks are that high. It's just like somebody with a holoprosencephaly. If the patient has a holoprosencephaly, the risk for trisomy 13 or 18 is 1 in 2. You cannot say, I want to offer you a screening test. What you want to do now is a diagnostic test. To just summarize this slide, because my main beef is people who just do nuchal and to tell women that you are okay, because we end up seeing some of these women for defects, and you are in a quandary, talking to a woman who told you, Chiremba was screened for Down syndrome, and I'm trying to tell her that you were not screened for Down syndrome. So it is this kind of practice issues that bring us to here to say we need to go back and have a discussion amongst ourselves and say, look, we can do better than this. So anti-normal is an indication to proceed with the combined, not to tell the woman to go home and rejoice. NT above the 95th, but less than 99th, that is less than 3 millimeters. It is again a reason to proceed and do the combined test or a fetal soft-genetic test if she can afford. Greater than 3 millimeters, it is an indication to do amnio, although in these days, because of how good fetal soft-genetic test is, depending on other factors, if there are no defects, we will repeat the scan fetal medicine, check the baby thoroughly, and if we don't see any other telltale signs for Downs, sometimes we can relax and allow the woman to do fetal self-genetic test. But we ask that we look for all the chromosomes in that fetal self-genetic test. So sometimes we do that, but ideally it is amniocentesis they should be offered, these women. So let's understand how to handle the NT. Please don't tell women your baby is normal because you've done NT. This is just our cohort, probably the slide which is of interest here. I just wanted to show you that only 2% of women present to us in first trimester, which is a very minute number. Out of the 7,141 women we have scanned, just 2% come to us in first trimester. This is a disaster for modern health, prenatal care. To have your population, only 2% presenting for proper assessment. Probably they will have presented somewhere else, but I just want to show you the kind of picture. I think our national picture is not far away from that, of course. Then only 9% of women actually get a scan for dating in first trimester. And you need to be trained to do a proper first trimester scan. You cannot just wake up and say, I can do it. You have to be trained. Even how to do nuclear translucency, you have to be trained. This is what I mentioned when we started, that we are living in the era of lifelong learning in the field of medicine. If you say you want to do it, just be trained. We offer a training platform. What we are urging you is to refer as many 11 to 14 weeks scan to us so that we can create a training platform to train our doctors now, our sonographers, our radiographers, and midwives today for the sake of future generation of Zimbabwean people, so that they can get the right kind of care from their doctors, nurses, and sonographers. So when you are trained and you can be assessed using the FMF website, your image can be assessed for competency. Once you do that, as a practitioner, you will be subject to regular yearly audit. Myself, I'm also subjected to a regular yearly audit. I submit my results every year for assessment to make sure I'm still doing it in the right way. That is the only way you maintain the license and also to maintain that application, because the moment you stop renewing your audit, that license is taken away because you become a very dangerous doctor to women to continue to practice without being audited of how good you are doing it or how wrong you are doing it so that you can correct. So there is a platform for learning. So there is no reason for you to continue doing them without wanting to subject yourself to a proper internationally recognized assessment where you'll be certified and you'll be known globally that if you send the results of your scan to UK and you say, I've screened for Down syndrome, they can see your FMF ID and say, look, this one is certified. We can believe his result. So it is important to want to comply to international standards. Just to show you the uptake of the aneuploidy screening, just look at this far-fetched pie chart. They don't worry about the rest there. You can see that 26% of our cohort here, which was a cohort of 320 women, and 40% of them are the ones that underwent 60% actually underwent screening, and 26% of them went for the combined test. And this is the private sector data. And I don't know where the percentage is here, but you can see it's quite a big percentage. The biggest percentage, okay, second biggest percentage here, probably 30% of them went for the NIPT. So do not think that women are not going for the fetal cell-free DNA test. They are, because they are modern Zimbabwean women. They have traveled everywhere. Our people want more and want better from us. So we have to improve ourselves for our own people, because they expect better. Because some people think nobody's doing that test. They are doing the test, and you have to offer it. If you don't offer it, they will be auditing the practice and say, how come I was never offered fetal cell-free DNA test? I've been reading that this is what should happen to me at 11 to 13 weeks. So then about 30% declined with their doctors. We didn't go downtown in asking why they declined, but most of them, they will tell you that it doesn't affect my decision, my pregnancy decision, in terms of whether they will terminate or not. They'll say, I don't care whether the baby is down or not, I will have the baby. So this is the majority of women who decline screening at all. And only 4% have the second trimester serum markers. We do not want to do this test at all. But unfortunately, our women booklet, and we end up offering this test. In the fetal medicine, we don't offer this test. We either offer a detailed fetal anomaly scan than this test. It performs better than this test. So we don't offer it really. All right, I'm going to save you this. This is our audit. We passed our audit there. I just want to give you an example as I finish my presentation. So when we say we have screened somebody for Downs, what do we mean? Look at this lady. What is her age? Okay, her age was 38 years, this lady. And for a 38 years old, the moment they walk into your room, their risk for Down syndrome is 181. That's their background risk, their a priori risk. The one that caused them to be given the jab in the 1970s, it is this risk. Then trisomy 18, 2,113, 1 in 2,113. When they walk into my room, that's their risk. For trisomy 13, is 1 in 5,033. Then after I have adjusted now their risk, I did the scan, I put in the nuchal translucency, the nasal bone, the ductus venosus, and the fetal heart rate. Then the risk was adjusted. You can see that the woman's risk is now very much improved, which reduces the likelihood for Down syndrome. So this is what we mean when you say we have screened somebody for Down syndrome. We can tell them that your probability is now 1 in 3,623. And we will ask the woman and say, are you happy with your probability? This is private practice. We'll tell her that our risk cutoff is 1 in 100. But look, there are some women, if you tell them that your risk is 1 in 200, they'll tell you, look, this risk is too high for me. Please go on and do another test or a diagnostic test. Because risk perception varies. In private sector, where you have to individualize the care, we have to tell them their risk and tell, this is your risk. Are you happy with it? That if we take 3,623 women such as you, only 1 woman out of them is likely to have a baby with Downs. If they tell you, look, doc, I'm happy with this risk, then you can reassure them and let them go home and enjoy their pregnancy. But you have to tell them these numbers, not to just say you are okay. It's not good enough. These are the other conditions we screen. You can see this woman was high risk for preeclampsia and so forth, and we had to put on aspirin. Right, so yeah, so I think I'll end here. I'll end here just to probably to remind you that when you are doing risk calculation, we have to input all these other women characteristics. They are very important in calculation of the moms, as well as the PAPI and beta CG, because they vary according to race, to whether women smoking, diabetes, the presence of all these other conditions. So they have to be taken into consideration. I think I will end here. Thank you so much for your time and for listening. I'll open the room for questions. There are two questions in the chat box. Mr. Kumbula, there is a question for you. Maybe you can start. Where TVS is not available, is there a cutoff margin that can be used to suggest transabdominal that there is a high risk for cervical incompetency? Mr. Kumbula, you can respond to that one. Then Audrey Mukombwe, we are in the fetal medicine unit at Salimugabe. Preterm clinic is one of the specialist clinics that fetal medicine units run. So like we say that we have a preterm clinic, surveillance clinic, we have a placenta disorder, we have multiple pregnancy, we have a fetal defects, we have a fetal cardiac clinic. So the fetal medicine is multiple clinics which are run by specialists there. So it's found in the fetal medicine unit at Sali. That's where we have a strong preterm surveillance clinic. It's run on Thursdays if you want to join them. Mr. Kumbula, are you still available to answer your question? Somebody's asking you that if I do not have a vaginal probe, can I assess this cervix transabdominally? And what are the cutoffs? Admin, do you want to, is Mr. Kumbula with you? Kindly respond quickly if he's not around so that we know and we'll move on. Mr. Kumbula. I do not think Mr. Kumbula is around. So what I'm going to do is during the questions and answer segment, I think I will just take you through the post question now. I asked you some few questions. I just want to put them up again. Then you can answer yourselves. I'll give you the answers. Then you can mark for yourself and see how well you are performing in terms of assessing. Just confirm with me, admin, did I change my screen to the quiz one? Admin, confirm if I changed my screen to the quiz one.
Yes, Dr. Verenga, we can see it.
Thank you so much. Thank you so much, Dr. Due. So which one is the ductus venosus? It will be quick. I think in 5 minutes should be done. Then we'll break for lunch if there are no further questions. So which one is the ductus venosus? So the red arrow corresponds to the ductus venosus where we see aliasing happening. So that's the ductus venosus. You can mark for yourself and see how well you are performing. The ductus venosus is normal. It is abnormal. We have a reverse A wave in this ductus venosus here. So it cannot be normal, this ductus venosus. The nasal bone is present. In this image, I would say it is absent because you can just see a continuation of the skin. You don't see much below the baby. Of course, it's slightly oblique. Maybe it's just a small part of the zygoma there, but it's not convincing that we have a nasal bone there. The echogenicity is the same in this, this baby. Which one is the knockout translucency? If you picked this one, let me put a laser. If you pick this one, it is not the correct answer. This is the amnion. So you will have measured the baby's back and the amnion as your NT. But if you did put this one here, that's the NT, the knockout translucency for this baby, not this one. This is the amnion, like I said, the amnion is not fused the chorion before 15 weeks. Trachea regurgitation is present. Yes, it is present in this image. As you can see, the regurgitation jet is more than 60 centimeters per second here. This is the arterial systole, like I highlighted. That's the end of the quiz. So in a situation where you can still use 25 millimeters as the cutoff, because I don't think Mr. Kumbula is around to answer the question. So you can still pretty much use 25 millimeters as your cutoff to measure.